Good evening, and welcome to AUA's Innovations in the Surgical Treatment of BPH live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. The AUA is accredited by the ACCME and designates this live internet activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the webinar. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA University to view Faculty and Education Council disclosures. The AUA would like to thank Olympus Corporation of the Americas and Teleflex Interventional Urology for providing independent educational grants in support of this webinar. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Please note that course participants are prohibited from using or uploading content you access through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. Finally, I'd like to extend a special thank you to our course director, Dr. Charles Welliver, for his time, talent, and expertise in developing this program. Dr. Charles Welliver is a fellowship-trained expert in men's health. He's the vice chair of clinical affairs and director of men's health at Albany Medical College in Albany, New York. At this time, I will now turn the webinar over to Dr. Welliver.
Good morning, midday, or evening, wherever you're joining us from, and welcome to the AUA's Innovation and Surgical Treatment of BPH live virtual course. The activity goals and learning objectives have already been released out to the group, but this is important as the AUA is launching an educational initiative for those clinicians and other healthcare professionals involved in the treatment of BPH. I'd like to now take a moment to introduce our excellent faculty for this evening. Dr. Paul Anderson is a consultant urologist at the Royal Melbourne Hospital in Melbourne, Australia. He is the Associate Director of Medical Education at the Royal Melbourne Hospital and an examiner in urology for the Royal Australian College of Surgeons. Paul, it's great to have you with us. Dr. Nicole Miller is a professor of urology at Vanderbilt Health in Nashville, Tennessee. She also serves as the Executive Director of the Endourology Division, the Vice Chair of Academic Affairs, and the Program Director of the Endourology and Minimally Invasive Surgery Fellowship. Nicole was also part of the most recent guidelines, and it's great to have her with us today. Dr. Jaspreet Sandhu is an attending urologist at Memorial Sloan Kettering Cancer Center in New York City, where he directs the Functional and Reconstructive Urology program. He is an Associate Secretary of the American Urologic Association and was Vice Chair of this recently released AUA BPH guidelines. Jaspreet, great to have you. And last but certainly not least is Dr. Nick Warner, who is a reconstructive urologist and specializes in all facets of BPH surgery. He practices at the Mayo Clinic in Rochester, Minnesota. Nick, thank you for joining us. Let's start by exploring the scientific process to create the BPH guidelines and how this process helps determine the results. So first, a bit about the data capture and methodology. For these new 2026 guidelines, the Oregon Health and Science University team searched Medline and Cochrane Library to identify randomized controlled trials and clinically controlled trials published and indexed. The search was then supplemented by reviewing electronic databases and reference lists for relevant articles. For medications, the data capture ran from 2009 to 2025, and for procedures from 2017 to 2025. Criteria for inclusion and exclusion of these different studies and data were based on the key questions in populations, interventions, comparators, outcomes, timing, types of studies and settings, or PCOTS questions of interest as were developed by the guidelines panel. The guideline statements have two different segments about the evidence, and the strength of the evidence is largely based on the certainty of the data. So there's the AOA strength of evidence category A, B, and C, which correlate with the grade certainty of high, moderate, and low. In the high or grade A category, the guideline committee felt that they were very confident the true effect of the therapy lies close to that of the estimated published effect. In the B or moderate category, the true effect is likely close to the estimate of the published effect, but there's a possibility that it is substantially different. In strength C or low, the true effect may be substantially different from the estimated effect. Of course, we need to link these statements to the evidence, and this is based on the level of certainty and the magnitude of difference between the benefits and the risks of that therapy. In a strong or moderate evidence grade, a directive guideline statement is created as there is a demonstrable difference between the benefit or risk for that therapy. A conditional statement would allow for a non-directive guideline statement, or a conditional evidence grade would allow for a non-directive guideline statement, as that risk versus benefit weighing is a bit unclear. A clinical principle is a widely agreed upon concept, but there's no evidence, or the evidence is outside the data capture for this guidelines. An expert opinion is a consensus panel statement based on the training, experience, knowledge, and judgment of the guideline panel. Let's dissect out a few statements to further understand this. So here we have the alpha blocker monotherapy statement. Clinicians should offer one of the following uroselective alpha blockers as a treatment option for patients with LUTS BPH. So this got a strong recommendation as the benefits certainly outweigh the risks. It applies to most patients in most situations, and future research is really unlikely to change the confidence in this at this point. Got an evidence level of grade A as we are very confident in the reported effect and there's a high level of certainty. This compares with guideline statement 27. In patients with moderate to severe predominance towards LUTS, clinicians may offer anticholinergic agents alone or in combination with alpha blockers as a treatment option. This got a evidence level grade C because the confidence in the effect is limited, and the true effect may be much different than the observed or estimated effect, and better evidence may change the confidence. It was a conditional recommendation as there is an unclear balance between the risks and benefits of this treatment option, and alternative strategies may be equally reasonable. The supporting text that goes with the statements is meant to be evidence-based, explanatory, and educational. While the randomized control trials and clinically controlled trials are used to generate the statements and are generally utilized in supportive text, authors may pull in other publications to help illustrate and reinforce important points. So I would make the, again, important point that reading the guideline statements is great, but I also highly recommend that you read the supporting text, as important explanation or caveats may appear in text that somewhat modify the guideline statement above. For instance, in the TERP statement, monopolar TERP was only recommended for glands less than 80 cc's due to risks or concerns about dilutional hyponatremia, and this really only appeared in the text. So while reading the statements is great, please also take a moment and read the text. All right, let's move over into our innovations in surgical treatment of BPH. What is new in these guidelines and how can our new statements be used to influence day-to-day patient care? First up will be Dr. Warner talking a little bit about behavioral modification.
Great. Thank you, Dr. Welliver. Okay, so when we look at the behavioral modifications, what we're really looking at, number one, is health of the weight. So making sure a patient is a good BMI, I think, is really important. We know that obesity has a higher risk of overactive bladder and lower urinary tract symptoms. Salt intake, of course, influences the fluid intake and fluid urine production, so very important. We all know that constipation can also press against the prostate and make it harder, and it's also an underlying physiologic outlet issue if somebody has chronic constipation. So really managing the constipation is super important. Particularly for the nocturia patients, we really want to work on fluid restriction, particularly right before bedtime. Usually we tell our patients 3 hours before bedtime just to make sure that they're a little dehydrated overnight. Good behavioral modifications, even if somebody doesn't have prior prostate surgery, learning how to do a proper Kegel exercise, which we know feeds back to the relaxation factors of the bladder, is a good technique, especially if they have a lot of urgency. And then um, really, there's no evidence of which of these to go forth with, but kind of shotgun approach in my practice. Try to go through all these and give them a handout that has all these listed. There have been several randomized controlled trials looking at the lifestyle modification, pelvic floor physical therapy, Tai Chi, weight reduction, and they really do favor these lifestyle modifications. So I think there's, as you can see, grade B evidence that really supports these assessments and these recommendations that we make for our patients.
And then
Okay.
Dr. Anderson will tell us a little bit about the new statements on combination therapy.
Thanks, Dr. Welliver. So I think we're mostly all very familiar with using combination alpha blockers and 5-alpha reductase inhibitors, and there's been strong evidence to support this combination for some time, and that's why we have a level B recommendation. This is because there's been some large randomized studies over many years that have supported the benefit of this combination over single agents. There are some caveats, of course. A 5-alpha reductase inhibitor is only really beneficial in those patients with larger, more glandular prostates, greater than 30 cubic centimeters, or a PSA of greater than 1.5. That's because that's how these medications work, by causing cytoreduction of the glandular elements of the prostate. The new guidelines, however, have some further recommendations. There we go. For some new combinations, as there is emerging evidence for some of these. Not quite as good evidence, only level C in this instance, because they are smaller studies. So adding a PDE5 inhibitor to an alpha blocker seems to have an added benefit. Of course, this is useful for patients who have concomitant erectile dysfunction, but is also effective in patients who do not have erectile dysfunction, so it can be considered for those as well. There's also been studies looking at using a PDE5 inhibitor with a 5-alpha reductase inhibitor, and this may be of advantage for patients who perhaps can't tolerate an alpha blocker, or who have been experiencing side effects from the 5-alpha reductase inhibitor, and this may be mitigated somewhat by the PDE5 inhibitor. And then, of course, we have patients who have predominantly will have a mix of voiding and storage symptoms. These are patients who have frequency and urgency in addition to their obstructive symptoms. And these patients may find a benefit of adding either an anticholinergic or a beta-3 agonist to their alpha blocker. And again, we now have studies showing that this benefit, these combination adds additional benefit and can be used safely and effectively.
As part of the new guidelines, a new procedural algorithm was developed, and Dr. Miller will fill us in on that.
Thank you so much. I'm really excited to be here. So the new procedural algorithm really changes how we use imaging. You can see when the guidelines were originally published in 1994, we actually recommended against imaging. But in the newest guidelines, imaging is key to choosing surgical therapies. And the other thing you'll notice in the algorithm is how many more therapies there are. Particularly with the introduction of a lot of new minimally invasive surgical treatments, particularly with the ability to now preserve ejaculation. The algorithm is now going to address how you might choose procedures based on size, as well as ejaculation preservation. So the algorithm is broken down into less than 30 cc's, 30 to 80 cc's, greater than 80 to 150 cc's, and greater than 150 cc's. And actually, we'll just go to the algorithm and I'll be able to show you the color coding. So if we look over here, we're going to start with the assessment of prostate size. You may also consider cystoscopy if you want to be looking for whether there's a median lobe or not, and I'll explain that why that's necessary. We then see the categories here of small, average, large, and very large. Of course, this 30 to 80 cc's, I think, is the sweet spot. It's going to be where you're going to have lots of options for patients. When we talk about ejaculatory preservation possible, you're going to see that in this dark darker blue color. And where ejaculatory preservation may not be as prioritized, it's going to be here in the light green color. Next, I want to turn your attention to these little asterisks and special designations. So particularly for the prostatic urethral lift, the temporary implantable prostatic device, and the intraprostatic drug-coated balloon, there should be absence of a median lobe. And then for the intraprostatic drug coated balloon, also you need to know the prostatic urethral length, which again is designated down here in the algorithm, which should be between 32 and 55 millimeters. We also, in the algorithm, talk about special cases, now addressing primary bladder neck obstruction, where you should consider TUIP, the temporary implantable prostatic device, or a TUR of the bladder neck. And then again, which is not unchanged really from the prior guidelines for patients that are at increased bleeding risk, the laser procedure, such as laser enucleation with holmium, so HOLUP, THULUP, PVP, and then added here prostatic artery embolization. And then one more comment about PAE is that it should be offered to men who have at least a 50 cc prostate. I think I've covered most of these bullet points in the review of the algorithm. The indications to consider surgery really are unchanged from the prior guideline. Patients with renal insufficiency due to BPH, refractory urinary retention, recurrent urinary tract infections, recurrent bladder stones, which you think are related to BPH, gross hematuria. And for patients that have LUTS and BPH that's refractory to other therapies, or if they don't want to use other therapies. You do not have to fail medical therapy in order to consider surgical therapy for BPH. Again, the procedural indications for patients with a bladder diverticulum are largely unchanged. We do not recommend treatment of an asymptomatic bladder diverticulum. However, in these patients, you may want to consider evaluating them for the presence of bladder outlet obstruction. If you do decide that the bladder diverticulum needs to be treated along with the bladder outlet, then you might consider a technique such as a simple prostatectomy where the diverticulectomy can be addressed. And then as far as follow-up recommendations, there had been recommendations for medication follow-up in the prior guideline, but not as much for surgical therapies. So in this case, we're making the recommendation that patients that undergo surgical treatments for BPH should be assessed for at least 1 year after surgery. You're monitoring for the development of any obstruction from complications such as urethral stricture or bladder neck contracture. And also, particularly with some of these newer minimally invasive surgical treatments, we know that the retreatment rate is going to be higher than for some of the other procedures. And therefore, you want to assess for any symptom return and need for additional therapy.
As we have more and more men now on active surveillance for prostate cancer, we have the opportunity to treat these men for LUTS due to BPH. And Dr. Sandhu will fill us in on the new statements for active surveillance BPH treatment.
Thank you very much, Dr. Welver, for this opportunity. As all of you know, active surveillance for prostate cancer has exploded. Active surveillance is classically used for low-risk prostate cancer in patients in whom we don't think prostate cancer is going to progress. And a lot of these men these days have pretty significant lower urinary tract symptoms. Now, whether that's related to BPH or prostate cancer is pretty clear. It's generally related to BPH, but it's LUTS in men on active surveillance for prostate cancer. And classically, we treat these patients just like men with LUTS due to BPH. So anti-blockers and daily PDE5 inhibitors are still acceptable options. And while there's an FDA black box warning on 5-ARIs that's specific to the not necessarily development, the detection of high-risk prostate cancer in men who are started on 5-ARIs, the FDA, at least in the United States, tells us that when we start men on 5-ARIs, we should talk to them about this consistent increase in the detection of high-risk prostate cancer. Whether or not that's a detection issue or truly a causal issue is unclear, But we do know that in men on active surveillance, this has not been shown to be all that important. So disease progression risk for 5-ARIs has not been established for patients on active surveillance. And providers should be, so there are a few studies that have been done on large populations of patients on active surveillance that have shown that 5-ARIs do not lead to progression of disease. So there's no difference in patients who are on 5-ARIs versus those that are not. And that's probably due to the fact that these patients are followed so closely with imaging. They're followed with imaging, it's unlikely that they're going to have a high-risk prostate cancer that is not present on imaging. So we feel very comfortable in using 5-ARIs in addition to the other medical modalities. Now, you should be cognizant of the fact that if you start a patient on 5-ARIs, PSA dynamics change. So PSA decreases by 50%, and you've got to reestablish a baseline for active surveillance purposes after 6 months of treatment. Now, this is well stated in guideline 61, which I'll let you read and go on to the next slide. And the next slide basically talks about procedural treatments. So we talked about medical treatments. We also think procedural treatments can generally be given to, or can be offered to patients on active surveillance for prostate cancer and should not be an issue for future cancer therapy. Now, there is one caveat. In patients pursuing radiation therapy, bladder outlet obstruction, reducing procedures should be addressed first, partly because of the risk of urinary incontinence in patients who have radiation therapy followed by one of these procedures. And there's very little data to support that radical prostatectomies and outcomes after radical prostatectomy are any different in men who've had a previous BPH procedure. So those can be, if patients progress in active surveillance, they can choose either one of those therapies. So non-ablative options should have no effect on PSA. That includes TWEEP, or transurethral incision of the prostate, urethral lift, temporarily implantable prostate devices, and intraprostatic drug-coated balloons. Those don't have any effect on PSA. You should be aware that prostate urethral lift has those titanium clips, and those can cause artifact on MRI. Now, while most radiologists have means of accounting for that, it still will actually cause some artifact in those areas. So moderate artifact in 19% of exams, and poor image quality in 9% of exams in this study from 2023. So that's stated in our guideline statement, which says PUL should be accounted for with PUL. So ablative therapies will reduce PSA. So it's important to reestablish PSA baseline after these procedures. Different procedures have different degrees of decrease in PSA. So it's important to note that. Patients pursuing ablative therapy may be more likely to discontinue active surveillance protocols. That may or may not be true, but know that used to be the case. And ablative therapies may produce pathologic specimens that may have benefit in evaluating men on active surveillance protocols. Now, that's only important if prostate cancer is in the transition zone. As all of you know, prostate cancer generally is in the peripheral zone, and all these procedures only get tissue from the transition zone. So I tend to look at MRIs, and if I think it's important to get tissue, I offer them therapies which gives good tissue, such as TURPs or open prostatectomies or OLEPs.
Great. Thank you so much to the panel members. Let's move into our next segment, talking about communicating patient expectations regarding treatment and maintaining a patient-centered focus. So with our armamentarium of medication and procedural options, we have a lot of varieties and a lot of little nuances with these options. So it's an important point is defining what means success to your patient. There's a variety of different things that might be important to them, things like the need for BPH treatment or retreatment, preservation of sexual function, or reducing or minimizing peri-procedural complications. So our new statements address many of these, particularly under the general procedural principles. There's some on education assessment of sexual function, some on bladder health and function, and looking at BPH retreatment rates. So first, let's talk about medication sexual side effects. Alpha blockers, these are mostly ejaculatory dysfunction and are very drug specific. 5-ARIs, we talked about that increased rate of detection, and that was an excellent point. It's not development, it's detection, and we don't know that there's any causality there. But 5-ARIs are also very challenging as they cause problems with erectile dysfunction, ejaculatory dysfunction, and also problems with libido. The good news is daily PDE5s have maybe the greatest sexual side effect profile of any medication, and that they have better erections. What a great side effect. So Dr. Sandhu, when you see men for initial BPH treatment options, and you do talk about alpha blockers, PD5 inhibitors, how do you decide who to start on what?
Well, I think you just answered the question, right? I mean, there are some men who come in who also complain of erectile dysfunction, in which case, daily low-dose tadalafil is always the right answer. But understand that tadalafil doesn't lead to an improvement in uroflow and so forth. So the only real drugs that lead to increased uroflow or flow rate are alpha blockers. So there are some men who are only bothered by markedly diminished stream, in which case you offer them alpha blocker. And in that case, you have to worry about ejaculatory dysfunction. And alpha blockers, while we say in our guidelines you should offer uroselective, all those have different profiles in terms of causality when it comes to ejaculatory dysfunction. If patients are worried about retrograde ejaculation or anejaculation, you should almost always offer them alfuzosin. Now that, of course, assumes that they're cardiovascularly and otherwise fit. But alfuzosin is the one that's got the least amount of ejaculatory dysfunction among the alpha blockers. 5-ARIs, as you know, can cause decreased desire or libido. But what's more important is they do often have ejaculatory dysfunction. So this is something we didn't recognize as much. But they often have decreased semen volume. Erectile dysfunction, obviously, is only with 5-ARIs. So it's important to note all that. The difference in men on who you're deciding between PD5s and alpha blockers, that's always a difficult decision. But usually it comes down to whether or not they have initial sexual or erectile dysfunction.
So along those lines, we have some new guideline statements about sexual function. And really, as doctors, one of our most important jobs is to be educators. So there's a guideline statement here talking about erection, orgasm, and ejaculation are all physiologically different, and these can occur independently. Patients may not understand what these different terms mean and how they are and are not related. So an important point with maintaining that patient-centered focus is to figure out their existing dysfunction. Dr. Anderson, how do you talk to your patients and understand their existing dysfunction? Do you use questionnaires? Do you just have an old-fashioned chat?
Well, there's certainly different ways of broaching these issues, and I think it depends a little bit on your practice. I have quite a linguistically and culturally diverse practice, so you really can't make assumptions about how patients understand these things. And some patients are more comfortable about talking about them than others. In my practice, what I like to do is I just sit down and draw a diagram of the lower urinary tract and where the prostate is and how it links up to the testicles and how it relates to the bladder, and actually start talking about the prostate and how its function is producing fluid that is part of the ejaculate. And I think once you start talking about it on physiological terms, that often is a good way to open up the conversation about what might be going on with their erectile function, what might be happening with their sex lives. And you get a feel for what sort of priority the patient has for these various issues. And then I think when you start to talk about therapies, you can refer to your diagram and explain, why it might affect things like ejaculation and how that all works. So that's how I do it in my practice.
It seems like, demystifying it is really a good thing to do to help patients talk about it. All right, so we also have some new statements about bladder health. Clinicians should counsel patients about progressive bladder functional changes associated with LUTS BPH. Men are living longer and our BPH procedures have just gotten safer and safer. Bladder function or changes are potentially non-recoverable. And there is this theory of move from normal bladder to overactive bladder or storage symptoms, and still with poor treatment or under treatment, areflexia or hypocontractility. There's some bladder hypoxia or damage to the elasticity or contractility due to continued obstruction that starts the cascade. And there's really no specific timeline from normal to problematic. This isn't a weeks to months. This is probably a years to decades idea. But this does still make a case for earlier intervention. When you guys offer definitive treatment to younger men, they're less comorbid. They may get the full benefit, and you can avoid some of those bladder changes. I'll urge you to look at Appendix 3, which looks at the different retreatment rates for all of our different options. We do have 1, 2, 3, and 5-year retreatment rates, but really this is often a longer game. So Dr. Miller, how do you talk to patients about 10-year retreatment rates or lifetime retreatment rates, particularly with this mix of studies that we have to make this appendix?
Yeah, I mean, I think you have to be very honest when you discuss with patient what the retreatment rates are, because, this being such a dynamic field, there are constantly new procedures being introduced, and you're not going to have 10-year data. But I think there's a reason why we keep talking about TURP many, many years later, right? So we know that the retreatment rate is low for procedures that remove tissue. And the retreatment rates are going to be higher for some of the mists. I think that patients just want to know as much as that you can tell them, and they're going to make a good decision based on the risk-benefit profile. And the retreatment rate is just one of the categories to discuss with them.
Yes, amongst the many. So other side effects, retreatment, BPH, or non-BPH specific, things like stricture and incontinence, sexual dysfunction. And there is some guideline statements looking at how these ejaculatory sparing procedures may increase the risk of BPH specific retreatment, as they do have a tendency to leave more adenoma behind after the procedure. So just to summarize this portion, it's important to define the existing sexual function of the patient, know and understand procedural specific retreatment rates and side effects, use prostate shape and size to inform your decision making, and to really understand the patient goals to find the right treatment option for your patient in this patient-centered approach. Move into the next portion, reviewing pivotal studies of some of our myths that are in this guideline. So the MISC guideline statement recommendations, really, as we said earlier, are based on the randomized control trials and clinically controlled trials that were registered primarily with the FDA. These different treatment options may get further indications in the future with Medicare or the FDA or your country's regulatory body based on these future studies. So you can see here that the similarities between all of these options and the guideline statement sizes, and this is largely related to those initial randomized controlled trials that were registered. So for prostate urethral lift, 30 to 80, no obstructing median lobe, water vapor thermal therapy, 30 to 80, 25 to 75 without an obstructing median lobe for the temporary implantable prostate device, and for the drug-coated balloon, 20 to 80, a known prostate urethral length, and again, no obstructing median lobe. Talking a little bit about water vapor thermal therapy. This is that initial randomized controlled trial with the FDA, 136 men undergoing treatment versus sham, see improvements in IPSS that outpace sham, and these were fairly durable out to 12 months. There's really minimal sexual dysfunction and no de novo ED, using a variety of different questionnaires to follow the erectile and ejaculatory function over time. They then went on to attempt to expand those indications to get beyond the 30 to 80. And here we see a meta-analysis of 15 different studies, over 400 men, all with prostate volumes greater than 80. We still see a good change in IPSS and Qmax. And then a comparison trial, randomized control trial versus TURP, so no longer against sham. 62 minutes versus 8 minutes in the water vapor thermal therapy. IPSS improvements in both, but better in TURP, but also more sexual dysfunction. So this really solidifies water vapor thermal therapy into our missed category here. Quicker procedure, maybe not quite as pronounced improvements in urinary outcomes, but less sexual side effects. Prostate urethral lift, the lift study, again, improvements over sham, durable out for years, really minimal to no sexual dysfunction. We do have the median lobe as an exclusion criteria in these guidelines, but they do have the MedLift study, which looked at treating men with a median lobe, pulled the median lobe across. Dr. Warner, I think you have some experience with this. Any tips or tricks on how to do this effectively?
Yeah, so UroLift, they come with a separate median lobe device, but it does work better, but I don't think it's necessary. And what I like to do when somebody has a median lobe, first of all, it has to be fairly pedunculated. It can't be just a little ridge of a median lobe. It actually has to be on a stalk. And then I choose whichever groove is the deepest, and I put my device into that groove and then into the bladder and almost sweep it backwards as if I was like bringing a finger back across. And what happens is that median lobe will kind of pop into the fossa itself rather than being in the bladder. And then you have a couple practice runs. Usually I'll use my last device that's been fired and practice it a few times, just pulling it into position. And once I get to a position I'm happy, I'll get the new device in, repeat the process, and then anchor it in. And you can see on the diagram here, you don't want to go too posterior with that anchoring. You do still want to keep it in the horizontal plane so that you're not going to fire it into any of the vasculature.
Right. So you're really trying to pull it into the prostate fossa when you're doing that. Okay.
Correct. Yep.
Cool. That's a great tip. All right, when we look at the MedLift study, this is men that had an obstructing median lobe, and when they compared it to the lateral lobe only group that didn't have median lobes, you see very similar outcomes with regards to IPSS, again, durable over time. Again, trying to expand indications, line size over 80, over 1,400 patients, 10 sites, and had reasonable efficacy still over 80 cc's and even over 100 cc's in a lot of these cases. This concludes our program today. Thank you so much. I hope you have a wonderful rest of your day, evening, or wherever you are.